I will.
I should have sent you the slide.
Oh, that's okay.
I'm putting down now.
I can't really see this. All right. Good to see you all.
I can't believe all you guys came before Thanksgiving. What a treat. I'm thankful for you all. I really am. We have this, Dr. Cameron. This is one of the providers I work with at Franklin's grad. So she's pharmacy electric rotation with me right now, so I'm excited for her to come and get a board review of osteoporosis medications. So excited to have her with us today too. And this is where we left off last time. Let me see if I think the lights are extra bright. Do you guys feel this way?
Yeah.
Okay, that's a little better. All right. So we left off with this case. So we'll reconvene here from yesterday. We've got a 51-year-old female with osteopenia. Wants to make sure she's doing all the non-farm things she can do. Keep her bones strong and healthy. She drinks 4 to 5 glasses of wine, smokes a pack per day. Oh, it's the same person we had previously, right? We already know. All right, so now that we've gone through all the non-farm things, what are 3 non-farm things that you can do? I'll have you think about them in your seat, and I'll have you share them just a minute. 3 non-farm things you can do to promote good, strong bones. Yeah, that's great. People had a moment. I just wanted to make sure people had a moment to think. I was that slow thinker in the classroom where all the other people would shout out the answer, and I'm like, I haven't even absorbed the question yet. Like, how in the world did they answer? So, yeah, exercise. Smoking cessation. Reducing alcohol. Yes. We don't normally call that cessation, but you could. I'm not sure. I don't know where cessation is only used in context of tobacco use. I don't know what it is. Yeah, those are all excellent. All right. Also targeting the calcium. So she's over 50, so ideally targeting 1,200 milligrams a day. You're talking about ideally from diet, if possible. Let's see here. If she does decide that she needs to supplement calcium, what are some counseling pearls for her? There's multiple different calcium products. What do you think might be the best product for this patient? I'm hearing a lot of calcium citrate. Why is that?
Because she's on the is also going to have the acidic environment needed for the carbonate.
Yeah, she's on calcium. She's on a proton pump inhibitor, pantoprazole. So the citrate we talked about is better absorbed than calcium carbonate if people are on proton pump inhibitors. So I think calcium citrate would be an excellent choice. Any other counseling points for her with her calcium supplementation? The constipation, that's interesting. They do list it as a side effect. So that could potentially happen. There's some evidence that shows that it doesn't necessarily cause constipation, but I definitely have patients say that it does. So it could be a potential side effect. How about with how she doses it throughout the day? Could she take 120 milligrams all at once and get it absorbed well?
No.
Ideally split it. Ideally she'd get at least half through her diet, right? So that she only has to supplement part of it. What hormone helps her absorb calcium better? Not vitamin C. Well, vitamin C does help you absorb calcium carbonate because it helps with the more acidic environment. But that's not what we talked about. Or something, what did we talk about right after calcium? Vitamin D. So most of the calcium products also have vitamin D in there as well. Both because people are often low in vitamin D and it helps with absorption of calcium. Alright, let's see here. If she did take calcium carbonate, she could, but just ideally would need to take it with food. I definitely think the citrate is the ideal option here. Oops, just gets you all the vitamin D things. How much vitamin D do you need? Yeah, anywhere from 15 to 30 micrograms per day. What was that in international units? 600 to 800. There are also two types of vitamin D. Which one did we discuss is preferred? It's a little better absorbed. It's actually the D3. Yeah. So that is cholecalciferol. Both of them are available over the counter. We did talk about the 50,000 international units is D2 is also available as a prescription if someone has very low vitamin D levels and wants to do them once a week. All right. Thank you guys got those things. Perfect. So we'll go on to the plan. All the medications. The fun part. Non-farm is of course very fun too, but this is extra fun. So there's a variety of osteoporosis guidelines out there. We've got the National Osteoporosis Foundation. Their guidelines are pretty old though and don't have a lot of our newer medications, but they do a really nice job kind of describing the pathophysiology of osteoporosis and some of the background and risk factors. So if you're ever wanting to read more about osteoporosis, doing a presentation on it, it's a really great resource. Then the American Association of Clinical Endocrinologists, or AACE, they also have a guideline, but it's specifically for postmenopausal women, so it doesn't include men, but it does include more of our newer therapies. And then the one that I am teaching from mostly today is the American College of Physicians 2023 guidelines. These include both men and women and include all of our newer therapies. All right, so similar to the treatment algorithm we looked at, I know this is a very, has a lot of information on it. We'll go through each of these things. So I'm not gonna go through them in super great detail here, but I think it's a helpful study aid to kind of categorize each of the medications for osteoporosis. So we've got our anti-resorptive agents, anabolic agents, and some that do a mix of both. And Dr. Mohammed will go over a little bit more of the mechanism of action. But it's nice to kind of categorize the classes of medicines in this way, because we'll talk about how you might use a sequential approach. So for example, and we'll talk more about this, you might use bisphosphonates for 3 or 5 years, and then when you stop those, you might do one of the other agents, or probably more commonly, you would do one of our other agents here, like denosumab, tirzepatide, trastuzumab, and then follow it by bisphosphonate. And so we'll use different types of agents. I'm doing a very poor job. We'll come back to this. I'm gonna just move on. Well, I promise we'll come back. But again, that slide just categorizes how those different classes work. So we'll start out here with a couple of the main recommendations from the American College of Physicians guidelines. So you'll see here that they recommend bisphosphonates as initial therapy for most women with osteoporosis. This has not changed over the years. This was also in our old guidelines from NOF as well. There's great evidence for our bisphosphonates. They work really well to strengthen bones. Let's see here. Bisphosphonates for males with osteoporosis. Some of our bisphosphonates have better evidence than others, and we'll talk about those in just a second. Denosumab or Prolia is second line. This is typically reserved for patients that are very high risk. Maybe they've already had a fracture on a bisphosphonate, for example. There's also some evidence for denosumab for males. Let's see here. And then, let's see here. Other things that I want you to take away from this. Basically, these guidelines highlight denosumab as being the recommended second-line therapy for most patients if they're not able to take bisphosphonates or they're very high risk. And then they have a less strong recommendation for our other newer agents like romosozumab, teriparatide, and some of our other agents. All right, so you might be wondering, she keeps saying very high risk. What is very high risk? These are patients that have had a recent fracture, or they've had multiple fractures while already on therapy, oftentimes with bisphosphonate. They might have lots of risk factors for osteoporosis, very low T-scores. What T-score did we talk about yesterday? Puts you in the range of being diagnosed with osteoporosis. Or maybe we'll take a step back. What was the normal? Yeah, so anything above -1 was normal. What was osteopenia? -1 to -2.5. And then anything over -2.5 was considered osteopenia. So they have very low T-score, so a large negative number, that could potentially put them at very high risk. That means that there are multiple standard deviations below what would be ideal peak bone mass. Or if they have FRAX scores greater than 30 for major osteoporotic fracture risk or greater than 4.5. What did we talk about as the threshold for starting treatment if they have osteopenia for the FRAX score? Let's review that too. It wasn't 30 and 4.5. What were the two numbers? For those that have osteopenia, but if they had this high enough FRAX score, we would start treatment. 9.3 was something. 9.3 means that you're at the same risk as someone that's 65, and so they're indicated for bone mineral density. So 9.3 is something important. But if they have osteopenia and we did their FRAX score, what score would lead us to treat them for osteo? Greater than 3% per hip. And then how about major osteoporotic fracture? 20. Yep. Excellent. So this is significantly greater than those numbers. So these people are at a much more elevated risk. So 30 and 45. All right. So we're going to talk more about bisphosphonates. That's our first class. This is still the mainstay of treatment for people with osteoporosis. And I think this next slide is Dr. Mohammed's on how they work. Or no, not quite yet. This is what happens when I stray too far from the slides here. So our cast of characters for bisphosphonates, there's quite a few. If you look on Lexicon, there's even more bisphosphonates, but these are the ones that are approved for osteoporosis specifically. So we got alendronate, risedronate, abandronate, and then we have an IV formulation, which is our zoledronic acid.
Hello everyone. Moving to the medicinal chemistry, the structure activity relationship of bisphosphonates is probably one of the first line drugs used for osteoporosis. Things to consider here is they are basically the congeners of pyrophosphate. So the only difference in bisphosphonates is basically the O group over here is replaced by which group here? If there's nothing there, what does it indicate? It's a carbon there, okay? So O is more hydrolyzable, carbon is less hydrolyzable. Why are we looking at less hydrolyzable?
Absorption, lipid solubility.
Lipid solubility, and we want it to be a hydrolyzable, but at the same time we also want to get more out of that drug, so it stays in the compartment where it needs to be for a longer time. So that confers, the carbon here confers that aspect of higher retention time. And then we also have your R1 and R2. What are R1 and R2? R stands for alkyl group. So we have your R1 group and R2 group. We'll come to it in a minute, but basically the idea would be to enhance potency retention in the active compartments for the most part. And these drugs belong to the category of anti-resorptive. What does anti-resorptive mean? So let's talk about what is resorption. Breakdown. Anti-resorption is opposite of breakdown. What is it? What? So the opposite of breakdown, whatever you call it, bone formation, or basically making the bones more harder. That's kind of what bisphosphonates really do. You're not responsible for basically remembering the structures, but what you really have to get out of this is, if you see those classes of drugs, there's always some difference. Like this is basically back in 1960s, 70s, whenever they started identifying and manufacturing these drugs. As you progress through the 2000 and 2025, wherever those drugs got manufactured, you could see like at the R2 group, which is basically your alkyl group, there's a lot of substitutions happening. One of the things for you to remember is the nitrogen. So whenever we have a nitrogen sitting here, okay, the more the nitrogen commensurate, the more the potency. And what is potency now? Potency, effectiveness. If you have to define potency in the actual terminology, what is it? P1 is far gone. Potency is, I wouldn't say efficacy, then what is efficacy there? The ability to produce an effect is efficacy. Affinity is ability to bind to the receptor. Potency is basically the less amount of drug required to produce more effect is what we look at potency. So if I'm saying that this drug is 100 times potent, what it means? I need 100 portion of zolendronate, basically when it compares to what is this called pamidronate. 100. So if this is 100 milligrams is what we really need, here 1 milligrams produce the same effect. That's how you calculate the potency. Okay. So just keep in mind the nitrogen group is the key for a drug to confer more potency. So there's a lot going on in this picture. One thing for you to remember is this is nothing but the same picture which we have seen yesterday, the bone remodeling cycle. What is the actual duration of a bone remodeling cycle? Duration. How much time? Starting from resorption to bone formation? 3 months, okay? So you're basically looking at 3 months, and it's divided into two different classes of cells. We have osteoclasts, basically taking the first stab at it. They basically break down the cells, whatever are really supposed to be resorbed, they get resorbed, and then we have osteoblasts coming into picture to form the cells. One of the key aspects is these are drugs which bisphosphonates are anti-resorptive. So what you can see is this yellow color icon here basically reflects to bisphosphonates, as you can see here. So these bisphosphonates have the ability, because they are more affinity and more efficacious and more potent, they basically get into the compartment before osteoclasts can get there. If osteoclasts cannot get there, they cannot resorb the bone. And if you cannot resorb the bone, they're not breaking the bone down. If you don't break the bone down, you basically, that is what we really expect from osteoporosis, that we don't really need that actual bone turnover, because that is making the bone more brittle. Makes sense? So the idea basically being that because of its ability to get into the compartment, they sit there preventing osteoclasts to perform this function. So osteoclast function is compromised. Simple. You have to remember here the enzyme.
Oh, is that a competitive activity or is it not competitive? I said, is it competitive?
We get to that. We get to that. We get to that. This is not antagonist. This is probably not. I mean, it's kind of around the same lines. We will get to that. So Kingsley's question is about competitive antagonism. We are not competing with osteoclast because it's not a receptor there. What we can compete is an enzyme or a receptor. So here is an enzyme. You see this enzyme FPPS, farnesyl pyrophosphate synthase. Okay, bisphosphonates has an ability to inhibit this enzyme. You will be responsible for this enzyme FPPS. So what is the function of FPPS first? FPPS has an ability to tag lipids to proteins. Okay. Just imagine that this is what is needed for osteoclast to perform what it has to do. If the lipid doesn't get tagged to your protein, it loses its function. That's what, and who is helping it? The FPPS. The nitrogen containing bisphosphonates has an ability to inhibit this enzyme. So what will happen? Lipids cannot tag to your protein. If there is no lipids tagging to the protein which is formed is mutated, it's compromised in its function, and that is what happened. Osteoclast loses function and undergo apoptosis, so bone resorption halts. Okay, things to remember: the enzyme and what is the function of this enzyme. So you can build a story from there. Got it? Can I move forward? Now let's check what is the structural difference between pyrophosphates and bisphosphonates. Carbon. I heard someone saying carbon. Okay, so where is that carbon? Bisphosphonates have a non-hydrolyzable PCP bond. What enhances potency and retention of bisphosphonate at its active bond sites? Is that calcium? Is it substitution with nitrogen, increased hydroxyl bonds, and high solubility? The nitrogen containing substitution moieties. How do bisphosphonates cause osteoclast apoptosis? By inhibiting the enzyme FPPS. What is the role of FPPS in osteoclast? Again, the answer is B. It attaches lipid groups to signaling proteins like RAS, RAB, and ROT.
All right. I apologize. I feel like the font's very small on this. I've been playing around with smart art on this slide. I find something that I'm really taken with. I think I change it every year. All right, so bisphosphonates, one of the reasons they're first line is they are by far cheaper than many of the other options. So I know I've got some price estimates on there. It depends on what resources you look. You could potentially find them cheaper than that. Even they've mostly been generic for a pretty long time. And these are, again, much less expensive than the agents that we'll talk about after this class. What's nice about them is they have lots of different dosing regimens. So there's monthly options, weekly options, or daily options. They're indicated for, they have great evidence for like all the things. They have great evidence for people with osteopenia that are on osteoporosis treatment due to their high risk. They have data for those that have been diagnosed with osteoporosis. They also have good data for those that are on steroids, have steroid-induced osteoporosis, and then even in the osteoporosis, which I'll talk about. There's not as much data with some of our newer agents in that population. So really strong data for bisphosphonates. They do work really well at increasing bone mineral density. The selection for this kind of similar to when we're selecting options within a class for diabetes. What did we talk about as kind of one of the driving factors in that? Or if we're trying to pick a bisphosphonate within the class, what would be kind of some consideration?
Cost.
Yeah, the cost. So what's on their formulary, which things are covered by their insurance, and then really how often they want to take it would be the other thing. So very similar to when we're trying to pick within classes for our diabetes agents. The IV formulation, this I think has potentially gotten a lot less expensive than in the past, but generally does require prior auths. I don't know, Dr. Cameron, if you have any experience from
Your patients definitely feel free to share it. In my experience, a lot of times this requires a prior auth that patients were not able to tolerate the by-mouth bisphosphonates. I don't know if you ever had a patient on the IV?
Yes, yeah.
Did you ever fill out any
Yes.
prior auth forms? Okay.
Yeah, that one took some time, so
Okay.
we got it done, but yeah.
Thank you for sharing your experience, because it's been on the market a long time. The IV class actually, I think we had a student, one of you guys from last year, that actually worked at Hopkins and would dispense the IV class. And they were like, it's actually not that expensive. And I was like, oh, well, they sure make us fill out a lot of paperwork for it. So good to know that it's still a prior auth process. So, generally, the IV would only be if they couldn't tolerate the keto. There are some counseling programs with bisphosphonates. I think of them a little bit similar to some of the counseling that we did with another medication together. So if you read this, it says, take this on an empty stomach, wait 30 to 60 minutes before eating. What other medicines did we talk about that had some similar counseling? Yeah, levothyroxine. Yeah, so this is a little bit similar to the counseling for that. Bisphosphonates are poorly absorbed, so it helps quite a bit with absorption if they follow these counseling principles. They're also very irritating to the esophageal lining, and so really important that patients don't lie down right afterwards. That can be really damaging to the esophagus, so important that they stay up, right, for at least 30 to 60 minutes as well. I was listening to someone talking about their experience in a long-term care facility, giving everyone their bisphosphonates. They were all on a once a week, and they were like, we would just strap them into their wheelchairs and make sure that they all sat upright for that 30 to 60 minutes and no one was napping, which I thought was a really funny mental picture. I see all these people in long-term care in their wheelchairs lined up getting their bisphosphonate therapy. So really important to not lie down right after. I see that you guys are not as taken with this mental image as I was. I don't know, it just really gave me the giggles when I thought about it. But anyways, moving on. So things to remember, take it on an empty stomach, separate it from food, and stay upright for 30 to 60 minutes. All really important counseling points. And since it was kind of a pain to take, I know if I were on a bisphosphonate, I would probably opt for one of the weekly or monthly options. You do not need to memorize this chart. I know it's a lot of different dosing, but I just wanted to kind of give you an appreciation for the different formulations. Again, we would kind of look to see what is it that their insurance covers, and then what would they prefer. Would they prefer to just take it every day? Would they prefer something once a week? Similar to our once weekly GLP-1s, if they do want to do it once a week, trying to tie it to something that they'll remember. A lot of times, Sundays make a nice time for once a week medications. I'll often set up a reminder on patients' phones and be prompting them to take it. Because something you take once a week is often very easy to forget. This chart also talks about some of the data behind each of the different bisphosphonates. And one thing I wanted to point out here is that abandronate specifically doesn't have quite as strong of data as the other bisphosphonates. So it has data specifically to reduce fracture risk in the spine, but doesn't actually have hip data and doesn't have data for men. So it's not approved for osteoporosis treatment in men and doesn't have quite as good data. So typically it's one of my lesser preferred bisphosphonates, but what is nice is it's available as a monthly formulation. There's also an IV formulation of that. I don't typically see patients on it. Normally they're on their D-class zoledronic acid because this one is just once a year. Once a year, yeah, isn't it? So it's nice, if you fight for it, get that PA approved, then they only have to go once a year, but it is an infusion, so they have to go get an infusion. All right.
And if you have side effects, you would be with side effects for a year?
I mean, yes, I guess, if they were to have side effects, well, normally it's just around the infusion time. normally it's like an infusion site reaction, so they'll pre-treat with like acetaminophen prior to it. So I think part of why it's not that it's like a slow release. Again, it's not a depot like we talked about with even doing the vitamin D. It's a fat soluble vitamin, but it doesn't actually have that effect. But its effects in the bone last, so that it's only needed for once a year. I don't know that I'm doing a great job explaining it, but yeah, that is one of the cons of things that are dosed less frequently. Is it does take longer for you to recover from any side effects. All right. So a couple things to keep in mind with bisphosphonates. The most common side effects with them are GI related. Again, they're very difficult to tolerate from a GI perspective, very irritating to the esophagus. Muscle pain, this has been reported in some patients. I can't remember if this is more with the IV. The infusion-related myalgias, those are, of course, just with reflux. They're not with the PO or by mouth bisphosphonates. We'll talk a little bit more about osteoporosis of the jaw. It sounds very scary, and I think it is very scary. This, I mean, basically it's like the jaw kind of like, for lack of a better word, like rotting or disintegrating. This is a very rare occurrence and is often in patients that are getting bisphosphonates IV for other reasons, for like cancer-related reasons, that they're getting infusions, not typically for the treatment of osteoporosis. Another thing that we've seen as a risk factor is patients that have like dental procedures. And so they recommend having any sort of dental procedure prior to starting your bisphosphonate. It's not something I've personally seen, but definitely sounds very alarming. And we'll talk about kind of with the atypical fractures too, with just the mechanism of how these work. They can potentially, even though they strengthen the bones, they can still have these kind of interesting side effects with bone regeneration in the jaw in some of these atypical fractures, which are generally in the femur. So osteoporosis of the jaw, very rare, however, also very alarming. Any dental work that they need to get done should ideally happen prior to starting with bisphosphonate. The atypical fractures are also like an odd thing that you'll see with bisphosphonates. These are typically associated with people being on bisphosphonates for a very long time, like over 7 years. And so we'll talk about on some subsequent slides that we generally don't continue bisphosphonates long term, and we'll stop them because they can cause these atypical fractures. Yes. Yeah, so the question is, if a patient is already on bisphosphonate and needs a dental procedure, what would you do? That's a great question. I would definitely let my dentist know and get them to weigh in on it. I'm definitely curious what dentist perspective is on bisphosphonates. Again, generally this is not an issue for people that are on bisphosphonates just for osteoporosis. But yeah, it would be alarming. Yeah. Yes.
I think it depends on the procedure. So for the regular procedure for such as endodontics or just regular removal of decay, I think it doesn't matter, but it matters when there is surgery.
It's major, yeah, definitely worse if it's major jaw-related procedures and really dealing with a lot of the bone in the jaw. That's a great point. Have you worked with dental experience?
So I have that.
Really?
From the
Oh. Are you making things up?
Not me.
Actually, I didn't realize this about you. I didn't know she was like teasing me. So thank you. This is perfect. That's exactly, you're exactly what I wanted to talk to. So more of an issue if you're having a major trauma. Thank you. We'll talk later about your dental history. I'm really obsessed with my teeth, so I'll probably have a lot of consults. All
right, so some other things to keep in mind here. So monitoring for the adverse effects that we just talked about on the prior slide. You actually are also recommended to check serum calcium at baseline and afterwards. I feel like, did I skip over something about calcium? Yes, I did. So it's recommended to check calcium levels before starting these and correcting them before treatment. They can actually cause low calcium or hypocalcemia. So monitoring that, supplementing as needed. It's a little controversial how often to check DEXA scans, depending on which guidelines you use. But in general, recommended to check every 1 to 2 years. And we talked about a lot of we don't do these lifelong. Their mechanism of action, their work in the bone lasts for years and years. So actually that's why after 5 to 10 years of therapy, it kind of depends on how high risk they are. So 5 years if they're less high risk, 10 years if they're more high risk. Years of therapy, we'll do what's called a drug holiday, which sounds very fun, I think. A drug holiday. You don't call stopping any other medicines a holiday, I feel like.
If it's a holiday, that means you can start again.
Say that again?
If it's a holiday.
Then once you start it again?
Yes.
No, you generally, it does make it sound like that. After you've done the 5 to 10 years and you stop it for the drug holiday, you generally do not restart them. Yeah, it does make it sound like you would though, doesn't it?
I know that some SSRI.
Some SSRIs, they do drug holidays for. You know, a lot of times, you guys will talk in CNS next semester about treatment for depression and anxiety. And a lot of times people will need some sort of treatment for life, but you sometimes can do a drug holiday where you stop them if they're very well controlled and they really want to get off of it. So yeah, again, kind of implies that you might start it again. I agree. But yeah, it's good. Thank you. All right. So this is just talking a little bit more about stopping it after that 5 to 10 years or that drug holiday. Again, maybe not a good term, but is like the common term that they use around bisphosphonates. And that's to prevent those atypical femur fractures we talked about earlier. Sometimes that mechanism, it ends up making these parts of the bones actually more fragile instead of stronger. I wish I could explain that in more detail, but that's kind of an interesting phenomenon there. So that's why it's recommended to stop these after several years of treatment. All right. So a couple other counseling pearls. We talked about already that it's best to take these on an empty stomach for best absorption, as food can really decrease the bioavailability of bisphosphonates. We already talked about having a full glass of water to kind of minimize the esophagitis that can happen and staying upright. And then for our infusion, our reflux, they'll pre-treat with acetaminophen to help minimize the infusion-related reactions. So a lot of these we've already talked about, and it's just kind of summarizing those counseling points. And this little dog here is doing a great job staying upright. All the bisphosphonates we talked about are generally oral tablets, but there is one effervescent oral solution. So if someone is not able to swallow an oral tablet and needs a liquid form, and their insurance covers this, it is, I think, the only liquid form of bisphosphonate on the market aside from the IV. I've never had anyone that's used it, but it does look tasty. It's strawberry flavored, but it is an effervescent. So you know, it's high in something. Does anyone know what? Effervescent products a lot of times are really high in something. So in sodium, yeah. So it has a really high salt content. I just have a little salt shaker on this slide, but I don't know if it's somewhere. All right. So our next agent is denosumab. That's the end of bisphosphonates. There's what questions do you have on bisphosphonates before we dive into our next speech? Which bisphosphonate are you guys seeing the most dispensed at your pharmacy? I'm curious. Alendronate? As the weekly or not remember how? Is that what you use the most? Alendronate? We don't really have that many patients on bisphosphonate.
We don't.
Or, yeah. All right. Sorry. Here we go. Back to the denosumab. So one thing that's exciting about the denosumab that I wanted to mention here before we got to the other slides that I just added this year is I saw that a number of them have gone generic and so have biosimilars. So these are monoclonal antibodies. So they have biosimilars as indicated with these letters off the end of them. So all three of these have just come to the market. I couldn't tell that they're necessarily available. I don't know if you have seen any of them. But the price of them should be coming down since the patent must have run out for early, which is exciting. All right.
Alright guys, coming to the mechanism of denosumab, it's a rank L inhibitor. Can anyone tell me where did you see rank L last time? Yesterday at 1 o'clock. Yesterday at 2 p.m. Can anyone tell me the function of rank L here? You will be responsible for that big cycle. You start with osteoclast, pre-osteoclast, osteoclast, and then the whole process repeats by itself. Alright, so where is rank L? It starts where
It's on the osteoblast precursor.
it's on the osteoblast precursor. Okay. So the idea behind the rate limiting step, as I told you, or whatever you call it, the most important step is the combination of your rank L on osteoblast versus rank on an osteoclast. They have to come together. For students who didn't attend my class yesterday, we have discussed this already. All right. So this is a monoclonal antibody. Monoclonal antibodies are basically designed in such a way that they are specific for an antigen. The antigen of choice here is RANKL. RANKL is the antigen of choice, which is basically present in the body of the person. Everyone carries the RANKL. We use this antibody, so it basically goes and targets the RANKL, and the dissociation constant is given over there. Okay. Here's the diagram, which basically talks about it. So we have your monoclonal antibody. Can anyone tell me, without looking at those icons on the right-hand side, tell me where and how do you identify a monoclonal antibody? It's a Y. So any of those Ys are basically your monoclonal antibodies. In this case, denosumab. Okay, and then we have your rank L, which is your green. Okay, so this rank L binds with the denosumab, and now the rank L is no longer available. So if you are going to get the rank L out of the equation for a second, what is getting compromised here? That rate limiting step. So osteoclast cannot combine with an osteoblast, and osteoclast cannot start doing what it has to do, where its function is to break the bones. So its function of survival is basically inhibited, and that's how you reduce the resorption. Okay, the key aspect here is humanized monoclonal antibody which targets rank L protein. That's all you need to know. But that all makes sense if you have attended my lecture yesterday and understood why we care more about this rank or rank L combination.
All right. So as a monoclonal antibody, I know we already had it on a slide, but how do you think this is given? What formulation? A sub-Q injection. Yep, a sub-Q injection. So this is actually unlike other injections, these have to be given in a healthcare facility. I don't think that we give Prolia injections at FHC. Have you ever seen that?
I'm really taking advantage of
Yeah,
these.
I think we do.
Do you sometimes? Okay.
Yeah.
So
Send it to 'em.
a lot of times endocrinology offices will do this, primary care offices can do it, but these are not something that the patient, it's not approved for the patient to inject themselves. But thankfully, it's only every 6 months, so it's just twice a year. So not as big of a burden as if they had to, if they weren't able to do their weekly injections of GLP-1s, for example. I've got the price currently, but I am hoping this price will come down as we have so many biosimilars on the market. And I kind of view denosumab as the first, second line option for osteoporosis. So if patients are very high risk or unable to tolerate a bisphosphonate or are not good candidates for a bisphosphonate, maybe they have a creatinine clearance under 35, then this could potentially be an option for them. I've certainly had patients on denosumab before. It is, like I said, the next most commonly prescribed agent for osteoporosis after the bisphosphonates. Even though a lot of times it is something that's started by endocrinology in my experience. As far as side effects, we'll talk a little bit more about these in a second, but as is what's listed with many of our monoclonal antibodies, you can have that anthralalgia, you can have cellulitis, you can have UTIs. They actually also have the same warning for the necrosis of the jaw that the bisphosphonates have. So again, ideally you would have any dental procedures or major jaw surgery prior to starting these. And a huge side effect of these is a decrease in calcium. So they actually are in a REMS program for hypocalcemia, especially in patients that have reduced renal function, which might not be uncommon for this because it's one of the agents that you can use if someone does have reduced renal function. But it has a severe warning about hypocalcemia. It has to be monitored prior to starting this and frequently throughout. So that's probably one of the things that I would start here is the fact that calcium monitoring is super critical. So bisphosphonates, they cause hypocalcemia, and then denosumab also can cause hypoglycemia. We'll talk hypocalcemia. We'll talk about some other agents in a second that actually cause the opposite. So kind of keep an eye out for this because it can be a little confusing when you're studying. Let's see. I think I hit all the highlights that I wanted you to have. So on to our next one, romosozumab.
So moving forward to romosozumab, the MABs basically are the monoclonal antibodies. And as you can see, it's a sclerostin inhibitor. So now tell me where we have seen sclerostin yesterday.
It inhibits osteoblast.
It is one of the factors which inhibits osteoblast. Okay, and what are osteoblasts responsible for? Bone formation. Okay, so we have your sclerostin which inhibits the bone formation. You inhibit an inhibitory, so your bone formation goes up. That's kind of like the mechanism. So again, it belongs to the class of monoclonal antibodies. So they have specific antigen over here, and which is basically your protein called sclerostin. So it targets that and it inhibits it, basically preventing osteoblasts to deteriorate lesser. So here's a diagram which talks in detail about it. So you have your romosozumab, basically a Y-shaped monomer sitting here, and it basically sends a signal to the sclerostin. Binds to the sclerostin. The sclerostin is not doing what it has to do, and it doesn't send a signal to osteoblast. And no signal sent to osteoblast basically means no osteoblast breakdown or differentiation. And that way, it basically helps osteoblasts to do the differentiation, formation, survival, and everything, whatever is required for the bone mineral density to be intact. That's what is a function. So remember, romosozumab is an inhibitor of sclerostin, and that's how it basically helps.
All right. So going back to the first picture on this one, you'll see this is also as another monoclonal antibody. It's another sub-Q injection. This one actually patients can do at home, and it's a monthly injection. One thing that's kind of interesting about it, and if I were the drug designer, I would not have done it this way. I should be a drug design consultant, I think. I have some good ideas, and I would definitely have mixed some things that came to market. Specifically, Spiriva as a capsule form. Like, that's ridiculous. Whose idea was that? Hopefully none of yours. Alright, so anyways, a ridiculous idea, again, is this one is actually 2 sub-Q injections. So each dose is actually 2 injections, which I think is odd. Surely they could fit a little bit more in there, but maybe they just didn't think you could absorb all of that fluid. I'm not sure. So it's 2 injections every month. This is the newest agent that we'll talk about to the market. So it's only been on the market under 5 years. I can't remember exactly when it was approved. It is pretty expensive, and kind of the main things I want you to know about it is its box warning for cardiovascular disease. So due to this risk of cardiovascular disease with this agent, it's actually, you can only do 12 doses or 12 months of therapy. And this is cumulative. So let's say you start it, you take it for 3 months, you have some sort of weird issue with insurance, which is not at all uncommon. And then you get that insurance issue resolved, but you missed a couple of doses, you still only have 10 more doses, even if there's a space between them, if that makes sense. So that 12 doesn't restart if you had unwanted drug holiday and then restarted it. So it's 12 lifetime doses of this medication is the max that can be used, and that's due to the increased potential risk of cardiovascular disease. So this would not be a good option, or actually, you should tell me, what kind of patients would this not be a great option to use in? Yeah, patients that are high risk for cardiovascular disease, patients that have had a cardiovascular event. What would we see in the past medical history? That would probably be a red flag against using this. Stroke, if they've ever had a stroke.
Uncontrolled hypertension.
Yeah, I mean, I guess even uncontrolled hypertension is a risk factor, probably not quite as like a clear contraindication as a stroke or a heart attack would be. So that's one of the things when I think of bromosuzumab that I think about is that it's a 12-dose max use, lifetime use, thank you, due to this cardiovascular risk.
How is it that the medication that has this risk can be taken at all?
Yeah, I think it sounds so scary that you're like, why would anyone ever take this? I've actually never seen anyone prescribe this before. Yeah, so it's not a widely used medication. I would imagine it would have to be someone that is just incredibly high risk where they decided, like, having breaking something is not a joke. I forgot to mention this story to you guys. So back when I was in school, this is actually from the person that did our hypertension lecture, but they would tell us this sequence of events, which I feel like is very true. Like, you're an older person, you take your blood pressure medicines, you get dizzy, you fall, you break a hip. Have I done this with you guys? You go to the hospital, you catch pneumonia, and then you die. That's the end of you sometimes. Like, so I think sometimes we think, oh, osteoporosis is not that big a deal, but while people don't necessarily die directly of osteoporosis, like, there are some really bad consequences to having it and breaking things. So I know this seems like a very scary medicine, and I think so too. I would have to have a very high risk and some reason why I couldn't take a bisphosphonate or I couldn't take Proteum. And then also just keep in mind, like, that's also why they limit the use to just 1 year, is to keep that risk minimal. They don't leave people on this for years and years. So I think it would take a pretty high risk specific situation for this to be started for a patient. Yeah, you bring up an excellent point. Let's see here. And then this one also has the risk for potential hypocalcemia. So just like the other two classes, bisphosphonates and denosumab, you'll want to check calcium and make sure that you're supplementing that appropriately if on this. All right, teriparatide.
Alright guys, moving forward with teriparatide. As you can see, it's a parathyroid hormone analog. What does it remind all of us? Parathyroid hormone increases calcium. Okay, keep that in mind because we're going to move to the next slide where we talk more about what this drug really and how it really helps. So it's a recombinant parathyroid hormone analog. So that's kind of like the structure of it, made up of multiple amino acids, at least 30 of them, or 34 amino acids. It's kind of mimic the structure of parathyroid hormone. So scientists are very smart. So they basically look at the actual parent drug and do some modifications, and that's your recombinant drug, which has more specificity, more retention power in the compartments, and so on and so forth. What we really need from this drug is two things. One, I don't know about the bone resorption, but definitely bone formation, because this is a drug used to treat osteoporosis. So in osteoporosis, are we looking at more of an osteoclast function or more of an osteoblast function? More of an osteoclast. So we want to inhibit osteoclast or stimulate osteoclast? Inhibit osteoclast. And what's the opposite of that? Do we want to stimulate osteoblast or inhibit osteoblast? Stimulate osteoblast. Okay, so that's what it really does. It basically helps twofold. One, basically by the way it is released or it's produced. As I told you, there are two ways we can give this drug. One is continuous infusion and the other one would be like the pulsatile or intermittent dosing. If you're doing an intermittent exposure, once daily injection, it favors bone formation. But the opposite, when you do a continuous high levels, it's going to favor bone resorption. So it depends on how and what you really need from this drug. It can be used in that way. Are we clear? Okay. Any questions? All right. Moving forward with the clinical.
All right. So similar to romosozumab, teriparatide is more like a third-line agent for osteoporosis, and bisphosphonates and denosumab would generally be considered prior to this. I just see that there is a generic available for teriparatide, but it is still pretty expensive. And I kind of think about it as being, it's an injectable, it's a synthetic hormone, kind of similar to like GLP-1s in a way. So those are injectable, those are synthetic incretin hormone. So I kind of think about teriparatide as being kind of a similar type of medication. You'll see that it is approved for both men and women, but is not generally a first-line agent. Some side effects with this is it can cause some pretty profound low blood pressure or orthostasis. So it's recommended that when patients administer this, and this is a once a day sub-Q injection, so more like Victoza, I guess, as a similar injectable agent. So this is every day, that you inject it while sitting, so that you don't have a fall from injecting it. The last thing we want for someone with osteoporosis is to have orthostasis and a fall from injecting their teriparatide. That would be ironic and tragic all at the same time, right? So it's recommended for them to sit. This one, kind of similar to romosozumab, also has a box warning, not for cardiovascular disease, but for osteosarcoma or bone cancer. So we'll take a look at that warning on the next slide. And this is the first agent we talked about that increases calcium. So since it's a synthetic parathyroid hormone, that's effect is to increase calcium. So the other ones we were worried about hypocalcemia. This one we're worried about hypercalcemia. Let's see here. Due to that risk of osteosarcoma or bone cancer, use of this is limited to 2 years. So romosozumab is a max of how many doses? 12. This one is a max of 2 years. Someone else.
Max of 2 years for the youth. And the doses.
Yeah, so that's a great question. I think like if you were to use it and then stop it, like it's still a cumulative thing. But since it's not, the other one, it's easier to say because it's a monthly thing, so you can just say 12 doses. This one with it being daily, it would be like quite a few doses. I'll double check it here, right? Which we should probably go on break, shouldn't we? Yeah, let's go ahead and go on break. And we'll reconvene at 2:40. I'm so sorry. Wow, we're so excited.
How are we doing? We're doing But then also,
And any something old school or it's writing up.
they had one that was like this, but it was great. It's great.
I should have interviewed you about this before.
Literally, it's one of these two psychotic, like,
Like I said, I think I'm sure we need a lot more, but no, I don't Well, I know we started actually, but Jennifer's going to be complete the she works right, so she got and it's the so I wouldn't prefer for it to be like an adult. Exactly. Yeah, I agree. No, exactly. So there's also like, oh no, you actually need to do all these other things. I'm like, oh, I had no idea. Okay, good to know. That's why I refer to you guys. Oh, yeah, no.
I feel like this hasn't provided that specialized.
Yeah. Yeah. To see that,
Let me know if you have. I'll send it to you.
You're gonna catch up on sleep under the Thanksgiving. I mean, so tired.
Lots of them,
You have a lot of things on Monday when you get back.
Wednesday.
Next week we have everything.
Really sad. I am sad.
EPKs.
I remember being a student and being like, no break is for real. There's always stress.
I mean, there's a little bit. There's a little bit.
Dr. Paul.
Yes.
So for the next PPK, it's going to be the same as before?
That's a great question. The next PT case. So the next PT case will actually just be women's and men's health. We're not telling you any proprietary information. This is what's on the television. So, meaning it will be cases from like Dr. Colhane and Dr. Graves. So they'll share a little more detail, but I think it will be a similar format. I don't know if they'll let you use any resources or not, but it will be just like a couple multiple like mini pieces on women's health.
Okay, so it's going to be the same format as before.
It should be similar, but might be a little.
Thank you.
How much time?
Oh, yes, yes, that was a mistake on my end. So,
That is
I would assume they will have to I
You're gonna look
in Puerto Rico, and it's the same. It's recording.
Oh, it's in my phone. Oh, it's just hanging out.
Oh my gosh.
All of us. I didn't really.
But you were talking about. Oh, that's my thought you're talking about. All these shows in space, just give him a time for that. What is that? I gave him a little.
All right.
Maybe finish the assignments. Here we are at 2:40. Hold on, me. And you started, so that we will be out on time. Alright, so Georgia, I did double check, and it is a cumulative lifetime max of 2 years. So if you had a break, it wouldn't start the clock over again. No more than 2 years due to that osteosarcoma risk. And this is what the actual risk looks like. I think this is another reason that kind of reminds me of the GLP-1s, is because it says due to studies in rats that we've seen this increased risk of osteosarcoma. So again, kind of similar to, what is this in studies in rats was the risk that we had for GLP-1s for what condition, do you remember?
Thyroid cancer?
The thyroid cancer, yeah. So it's kind of a similar type of warning. So due to studies in rats, we've seen this increased risk. So patients that would be
usually at an increased risk of our osteosarcoma, and gives you some examples of what that would be. We would recommend avoiding this product in those patients. For a lot of these things like romosozumab, teriparatide, and even the next one we're going to go through, these are not super commonly prescribed medicines. They're pretty expensive kind of specialty medicines. And so I think for purposes of like your working knowledge of them, being familiar with some of these major warnings and some of these kind of key points is probably the most beneficial thing for you. So I'm not going to have you necessarily memorize all the dosing, although I think the frequency is a helpful thing to know. Are things that they could potentially ask you on an Applex. Applex loves a good box warning, so I want to make sure that those are things that you know readily off the top of your head. All right, so teriparatide is available in these pre-filled syringes, and it's all once a day injections, so similar to like Victoza or once daily long-acting insulin. Same kind of counseling, you'll rotate sites, you'll use a new pen needle every time. These do need to be kept refrigerated and then dosed immediately after they, the dose, it needs to go back in the refrigerator after dosing. So that's one difference between this and our GLP-1s and even insulin, because you can do a dose of that and it can stay at room temperature. This does need to go back in the refrigerator. So in case you find yourself as a specialty pharmacist for CVS, where you are counseling patients on this type of product on the regular, these are some important counseling pearls for patients that are taking this product. All right, so very similar to teriparatide, there's another agent in this class. It's a little bit newer, abaloparatide. It's been in the market though for I think over 5 years, so it's older than romosozumab. And I'll have Dr. Mohammed share the difference between this one and teriparatide. Do you want one of these?
Alright guys, so for the abaloparatide, it's more or less similar to the teriparatide, which we have seen the same idea about the recombinant DNA technology to produce this drug, which should mimic the human parathyroid hormone. So that's what it looks like, okay? And then we have abaloparatide, probably 38% similar to this hormone, which is your parent hormone. The idea behind this being that selectivity, stability, and more anabolic potential. These are the three things you have to remember. Please write it down somewhere. What we really want to get out of this drug is selectivity compared to the parent hormone, which is your parathyroid hormone, stability, as well as more anabolic potential. Just by tweaking some amino acid sequence, we can get there. That's the idea.
So I just saw in my notes, this came to market in 2017, so 8 years, I guess. However, the indication to add MIN to the approval was just in 2022, so that's been a newer development of abaloparatide. So very similar to teriparatide, this is also a once daily injection. It's also pretty expensive. It's very similar, it has the same box warning. It's the same side effects as teriparatide, the same counseling with making sure that patients are either sitting or lying down due to that orthostasis, and the same max use of 2 years due to the osteosarcoma. So everything is very similar. There's no real big differences between the two here on these slides. Let's see here. I guess one thing that is a little bit more severe is their warning against the orthostasis. So this product specifically says that it's recommended to monitor patients for 4 hours after that first dose. So that first dose would be done in the office so that they could be monitored for orthostasis. So here again is the same warning for teriparatide. It's also available in pre-filled syringes. Counseling is very similar. So the one difference here is that it can be stored at room temperature after that first dose and doesn't have to go immediately back in the refrigerator. All right, so we've made it to our patient case again. So let's see here. So now our patient, a little bit more information. We're seeing her in the future, and her T-score has changed. It's now negative 2.6. Negative 2.6? Well, we'll get there in a second. She would prefer not to have to take any additional daily medications if she can avoid it. You see her past medical history and meds are the same. What is your assessment of her T-score? Osteoporosis. Iron. What's the range for osteoporosis? Yeah, negative 2.5 or less, meaning but it's opposite what you would think because it's a negative number, so a larger negative number. All right. So I agree. She's now eligible for treatment because she falls into one of the 3 treatment buckets we talked about. What were the 3 treatment buckets from yesterday? 3 types of people we treat for osteoporosis. You guys just need one of them. For those with a T-score of negative 2.5 or less. What else? They have, yep, if they actually have a fracture and a fragility fracture, if they have a fracture from no more than standing height. So we said that would actually meet criteria for the diagnosis of osteoporosis and they're eligible for treatment. Then there's one more treatment bucket. Yeah. Yep, if they have osteopenia, so a T-score of negative 1 to negative 2.5, plus a FRAX score for major osteoporotic fracture risk of at least 20%, and hip of 3 or more. Excellent. So this person fits neatly in the bucket of their T-score being less than negative 2.5. All right, so in addition to the non-pharm things that we already counseled her on at the very beginning of class, what treatment would you consider for them first line? I'll let you kind of think about it there in just a second. What you think might be a good option. She says she would prefer not to take something daily, if possible.
Once in a year, one injection. I go straight once in a year, one injection for the whole year, that's fine.
Yeah, you want to go ahead and put her on reclass, right?
Simple. One injection.
Have fun with that prior authorization, right?
Yeah,
So they spend 2,000.
get the prior authorization 1 year and you're done.
Oh, the CrossFit.
22K, is that the one?
For reclass, I actually don't think that reclass is that expensive, but it requires prior rounds.
If it's 1 year, if you divide it by 12, it's even cheaper.
Yeah. I think George, you said something.
Maybe eventually, because she's postmenopausal, right? And
Yeah,
that's
she would
one thing.
fit. She would fit in the category for Evandronate. Yeah, so Resedronate or Evandronate, they both have monthly options. So kind of see what's covered by insurance. If insurance covered both of them, I would probably prefer Resedronate because it has a little bit better data because it has data for both hip fracture and spine fracture. While Evandronate only had the vertebral or spine fracture data. And these are both once monthly options. So it wouldn't be another pill that she has to take every day. Let's see here. Say that again.
Once in a year, I better have this.
Yeah, because in order to get IV reclass approved by prior auth, you only have to have evidence that they couldn't tolerate an oral bisphosphate. So if we had endless money in the world, yeah, maybe we would. Not all patients necessarily want to be on an IV, have an IV infusion though. So I know it does sound nice that it's just once a day, but not all patients are necessarily going to want to do that anyway, even if insurance did cover it. So it's normally we only do that if patients can't tolerate the by-mouth bisphosphonates. Okay, so how would you counsel her about the risedronate or evandrate? Yeah.
And so just going back to the point, I know that, so in my first summer after first year, I worked with long-acting injectables in Safeway, mainly antipsychotics, and there was a big focus on like starting them on orals and then switching them to injection. Did I miss that, or is that not the typical route that it's followed?
Yeah, this makes a lot of sense. So you guys will talk about the long-acting antipsychotic injectables in psych next semester, and they're kind of a different situation. So those are our actual lethal injections, like you've kind of been asking about. So they get that injection and it gets absorbed over a slow period of time. And that is a recommendation. You try to make sure that they tolerate it first, so you don't start them all on oral, and then you can transition them to a long-acting depot injection.
Because this one is not a depot.
But these are not. It's not a depot. It's an IV. It's an IV, so it's not like an extended release duration of action. It's a different type of formulation. If that makes sense. So this one, you don't start them necessarily on a PO bisphosphonate with the intent of switching them to an IV one. It's not the same kind of philosophy, if that makes sense. But you're absolutely right about how that works with the long-acting antipsychotics. For those, it's also like very beneficial because for those kind of disease states, you don't want the patient to have to remember to take it all the time, and so that long-acting depot is recommended. So it's kind of a different situation. Yeah, these are great questions. So what are some counseling points? Let's say when you start them on a once monthly risedronate, what would be some counseling points for her when she picks this up? Someone really, really loud and clear.
Take it on an empty stomach, like 60 minutes food, avoid cancel the kinds of food to avoid like calcium rich foods, coffee. Advice are also after taking it should sit upright for like 60 minutes to prevent irritation of the esophagus as the medication can cause.
Very fair. Vera, anything to add?
I think like sitting or something.
Yep, so wants to remain upright for at least 30 to 60 minutes to avoid the esophagitis. Like Jordan, take it on an empty stomach, 30 to 60 minutes before food to help with absorption. And then another thing that you mentioned was separating it from other vitamins and minerals and other medications to help improve absorption as well. Excellent. So take it also with a full glass of water. I think you guys said that too. Ideally 60 minutes before the first food of the day, prior to calcium and other medicines. Avoid laying down for 30 to 60 minutes. And then I like to let patients know like this is something you'll probably be on for 5 to 10 years to kind of give them a time frame. I know this is something that patients often ask me with their diabetes meds, well, I have to be on this for life, or they'll ask about hypertension meds. So I like to give patients kind of a potential time frame to keep in mind.
I wonder if you hear side effects, right, and situations where patient like tend to need to prevent that.
I'm so sorry. Say that again.
The GI effects, right, and the situations like patients tend to eat to prevent that.
Yeah, the GI irritation. The GI irritation is more like that direct. Like some medications, do cause stomach upset, and taking it with food helps. But bisphosphonates are like directly irritating to the esophagus. So the things that minimize it the most are staying upright and taking the water with it. So it's kind of a different philosophy than other meds that cause GI upset, if that makes sense. But taking it with food wouldn't necessarily minimize that irritating effect, and would just reduce absorption. Yeah, there's different. So I guess when you say GI effects, it could mean a lot of different things. So this one's specifically that irritation to the esophagus. All right. What other questions do you guys have on this piece? All right. We'll move on to raloxifene. You'll notice, have we talked about raloxifene from the guidelines perspective? When we're looking at the 2023 guidelines, did they mention raloxifene at all? I know I bumbled through those slides kind of quick, so you may or may not have caught it. But they actually don't mention this medication. It has a really interesting mechanism, and we'll talk about the specific situation that you'll use it. But we'll go through the mechanism first.
Alright guys, talking about raloxifene, based on those AAC guidelines as you mentioned, very briefly I have glimpsed through it as Jose was asking the question. So the way those guidelines really are split into is always the first line is bisphosphonate if there is no prior fracture. And if there is a prior fracture, then we basically talk about denosumab, aborotide, teriparatide, and all of that. So always oral first line, insurance covers it. That's how I look at it. Moving forward with raloxifene, selective estrogen receptor modulator. One of the things, as you can understand and think about, is we have agonist and antagonist. So here's the problem we are going to deal with this drug. We understand that we need estrogen, and we need higher estrogen also causes cancer. There is estrogen which can help you and be more protective, and there is estrogen which we don't need in tissues which can cause cancer. Okay, so we need estrogen in the bone, but we don't need estrogen, high estrogens in breast and uterine tissues, because the high estrogen basically is a recipe for cancer in those tissues. Having said that, so scientists have found out that can we identify or synthesize a drug which can act as an agonist in one part of the body and an antagonist in another part of the body. Interesting, right? Okay, so that's what we call as modulators or receptor modulators, positive or negative. For the most part, this drug is a selective estrogen receptor modulator. What it means is that it modulates the receptor based on where it is present. So if I ask you now, with whatever I have spoken in the last 30 seconds, can you tell me where we expect this drug to act as an agonist? Where we expect this drug to act as an antagonist? Breast tissues, uterine tissues. Why? For cancer risk. We discussed this, right? So this drug, we expect it to act as an agonist. It doesn't work. We expect this drug to act as an agonist in your bone and an antagonist in your estrogen, your uterine tissues. So here's the structure-activity relationship. What you have to be looking for is this different classes or different structures. We have your phenolic hydroxyl group as well as your phenoxyhydroxyl group of C3 and C11. This is important for receptor binding and selectivity, whereas the one which is in the red, which is the piperidine ring, the one with the nitrogen, is important for receptor conformation. Okay, why it matters? It matters because on the next slide is what we think about it. So we are looking at first, forget about B. You're not looking at B right now, you're only looking at A. The A is your estradiol. Estrogen cannot be just, like the pure form of estrogen is really not manufactured as it is. So we have the formulation which is out there for experimental and for other purposes would be estradiol. Okay, what basically means is it's a formulation of estrogen. If you can see this drug as it is shown here, you're not responsible for the structure, so don't freak out. What you are responsible for is understanding how they are different from each other. So we have on the left your estradiol, on your right raloxifene. This is a pure estrogen agonist. This is a pure estrogen agonist in the bone and antagonist in the uterine tissues. And what does it stand out as you see the structures? Just like identify the differences. This is more slimmer, this is more wider. Okay, so this wider the wider nature is actually the wider nature of this drug is important because it creates a hindrance. As you can see, it creates a hindrance against the receptor. So whenever this drug goes and hits on the uterine tissue, it hinders its binding over there. And that way it acts as an antagonist. So that's kind of like the cue. But for the most part, agonists, because it mimics estradiol, so it should basically act as an agonist on your bone. But on the other side, this big, large substituent on the other side, this doesn't work. So any of this, the ones which are highlighted in red, they confer steric hindrance, and that is important to provide the antagonistic property. All right. So, as we have already discussed, this is a drug which acts as an agonist in bone tissue and an antagonist on the other parts of the tissues like breast, uterine, and ovarian tissue. There is evidence to some extent that how does estrogen play a role? And this is interesting, right? As you think about it, we talked about steroids. Estrogen or testosterone is kind of like a sex steroid I would talk about, right? They are basically coming from the same adrenal cortex. So we have adrenal cortex divided into three different types. We have zona glomerulosa, zona fasciculata, and zona reticularis. The zona glomerulosa is the one which produces glucocorticoids. The zona fasciculata produces mineralocorticoids like aldosterone, and the zona reticularis produces the sex androgens, which are testosterone, estrogen, and so on and so forth. Things to remember. We talked about two steroids here. One, glucocorticoids, which is not good for the bone. On the flip side, estrogen, testosterone are good for the bone. You see how they are different? They are both steroids, but one of them is bad, one of them is good for your bone. So you just have to think about that as you start learning. And what evidence shows us that they are responsible for production of osteoblasts, basically meaning that they stimulate osteoblasts to do this function, which is bone formation, and inhibit the osteoclast activity. All right, let's do a quick knowledge check here. So going back to whatever we have learned, we did learn a couple of drugs, denosumab, teriparatide, abaloparatide, and then we also had the last one, raloxifene. The first drug is denosumab. What's the mechanism of action? It's a rank L inhibitor. So whatever shows your rank L, I'm sorry about this. I stole the thunder from you guys. The romosumab is your sclerostin inhibitor, right? And then how the sclerostin affects bone remodeling. We're not talking about romosumab here, we're talking about sclerostin. What is its function in the bone remodeling? It inhibits, stimulates, what is it? A, B, C, D. A, it inhibits osteoblast differentiation and activity. So you understand this? So if you understood that slide, romosumab comes and inhibits this, and that osteoblast differentiation is possible. What about teriparatide? It's an analog of which hormone? Parathyroid hormone. What is the mechanism of raloxifene in the bone tissue? It's an agonist in the bone.
All right. Thanks. So raloxifene, just based off of that mechanism, do you think this is approved in both men and women? No, just women. Which I think makes sense. And its use is specifically for patients that are high risk for breast cancer. So typically it's actually used more for that breast cancer risk reduction, and it's kind of just an added benefit that it helps maintain bone mineral density. So this is kind of a very niche indication for this medication. We'll talk about some of the reasons for that. One of them is this mechanism does help prevent bone mineral density lessening since it has these estrogen effects. The estrogen effects on bone mineral density are not anywhere near as potent as something like a bisphosphonate or the denosumab that we talked about. So this is a lot less efficacious than our other agents for promoting bone mineral density. So kind of keep in mind, this is something, it kind of has the added benefit of osteoporosis treatment, but kind of the main thing is breast cancer prevention. So we wouldn't start this on someone unless we needed that breast cancer risk reduction. One of the reasons for that is due to the side effects. So hot flashes, leg cramps, so these are due to those effects on estrogen. You guys talked about with, now I forgot my name, but like Dr. Colgan and our guest lecturer about the effects of estrogen and how they can increase venous thromboembolism risk. And so we have that same risk with this agent too due to those estrogen effects. So this agent also has that warning. So it is not a first-line agent. So patients to avoid in, definitely patients that have had a past VTE, so whether that be a pulmonary embolism, a DVT, if they've had a stroke, then this would be not recommended in those patients. And then just to kind of reiterate, the data for this is not strong. It also only has vertebral data, so similar to what we talked about with evanadrine, but probably even a little bit less benefit than with that. We only talked about that one briefly. So what's, oh, never mind actually. Okay. So we'll talk about a couple special topics here. So sequential therapy is one of the things that I kind of mentioned when we were looking at that algorithm before. I don't know how long it will take me to get back there. But sequential therapy with anabolic followed by an anti-resorptive. So if we go, let's see. This is going to take me too long. Whew. Dr. Mohammed, could you change the slide to the one with the chart that we, oh, not that far.
55.
Yep, 55. Thank you. Yeah. All right, so back to this slide I told you that we would be coming back here again. And this is to kind of discuss sequential therapy. So if you were to start like a teriparatide or abaloparatide or romosozumab, with their mechanism, often you would just do them for, I guess, the 1 year max with romosozumab or the 2 year max for these two. And then it's recommended to follow it by an anti-resorptive if you can, if these are these are very high risk patients, or we wouldn't be using teriparatide or romosozumab in the first place. When you stop teriparatide, abaloparatide, romosozumab, or even denosumab, you lose the benefits from them right away. So they don't have long-term benefits. If you stop the bisphosphonate, those are built into the bone matrix. You continue to get benefit from those for many years. And so that's why you're able to stop those, but are not able to, if you are able to stop the other ones, but you just lose the benefit. So a lot of times if we do one of these three, or even Prolia, we'll follow it by an anti-resorptive.
Can we, there's a, like a little bit, there's of the black light, letter, writing, it's a little hard.
Oh.
It's supposed to kill the lights a little.
Turn them down. Yeah, for our last 10 minutes, it'll be less bright, perhaps.
Oh, because we fall asleep.
I feel like I keep hitting these, but that I don't know. It just seems to get brighter and brighter, doesn't it? I'm not sure how this happens. Alright, so that's why categorizing this can sometimes help. If you're on an anabolic agent, or really any of these agents here, then a lot of times we'll follow them by a bisphosphonate. Another thing is you would never, sometimes they'll use both agents at the same time, although pretty rarely but you would never use two anti-resorptive categories at the same time. So you would never use raloxifene plus a bisphosphonate or denosumab plus a bisphosphonate. So that was the other thing I kind of wanted to point out here. Everybody's screaming us. Thank you so much. I apologize. I should really just move this slide. I'm gonna do that.
This way?
I've reflected and I'll move this slide in the future.
Or this one?
Back to the one you were at before. All right, so it's not recommended to use anti-resorptives together. We would use sequential therapy like we talked about. And this just says what I said verbally. When you're using abaloparatide, teriparatide, romosozumab, or denosumab, you'll often follow those by a bisphosphonate, since you lose the benefits from those as soon as you stop them. This chart just summarizes the length of treatment duration for the different agents. So we've talked about each of these sequentially, but I thought it'd be helpful to just put them all on one slide to summarize it. For our oral bisphosphonates, we talked about max use is 5 to 10 years, and that's to prevent the atypical fractures that we talked about. For IV bisphosphonates, I don't think I mentioned this previously, but it's an extra potent formulation of the bisphosphonate. So actually, if you need a shorter duration, if you do the B class, and it's 3 to 6 years. Prolia, or denosumab, is similar to the oral bisphosphonate duration of action. Then teriparatide and abaloparatide, 2-year max. What box warning was the 2-year max for? Not cardiovascular. Osteosarcoma. Yep. So osteosarcoma of the bone was the 2-year max for those. And then romosozumab has the 12-dose max due to cardiovascular disease.
I remember in first year we joking about the fact that Prolia has like 19 common side effects, at least the ones that they used to make us learn in top 200. Are they that common, or is it just that they have a lot of side effects with the profile, like the frequency of them is not that much? It's like you could have a very long list of side effects but not seeing them.
Right. Yeah, that's a good point.
Like your experience, do you see people like struggling a lot with those side effects?
A lot of side effects. So I've only had a handful of patients on denosumab, and they've tolerated it well. So more often I would see like the GI or the esophageal irritation with the bisphosphonates. I don't know. I haven't seen people that have had cardiovascular events from romosozumab, for example. I don't know if that's kind of what you're asking.
Yeah, specifically I know Prolia, which was the one that we
Is that how they're called 200?
Yeah.
You know what? Okay. Doing some reflection.
But it might be like a bunch of
A long list, but not really the high incidence. Yeah. That's why I like to look at side effects on micromedics, because they normally will put the actual percent incidence. And as you can see, are the common ones really that common? Because you're right, you could have a whole list, but they're not very common. You bring up a great point. Just real quick, osteoporosis and MINT, we've already alluded to it, but just wanted to kind of reiterate that there's not really strong evidence for routine screening of MINT. However, the National Osteoporosis Foundation does recommend bone mineral density if if men are 70 or older. Most of the data for treating osteoporosis in men is with alendronate. So that's typically the preferred bisphosphonate. There's also data with zoledronic acid and with risedronate, but which bisphosphonate do you not see there? Which bisphosphonate do you not see? Evanthronate, our once monthly evanthronate, it does not have approval for osteoporosis in men. And teriparatide and abaloparatide, and denosumab are all second-line agents that can be used in men. So just this slide just recaps which agents are approved in men, so kind of similar information to what we talked about. And so right now, bromosuzumab and evangeline and riboside are the only agents that would not be approved in. Glucocorticoids we talked about quite a bit yesterday are the biggest medication risk factor for osteoporosis. Treatment is the same if you have steroid-induced osteoporosis, but one thing I wanted to point out that it's really important for patients that get steroids to get at least 1,200 milligrams of calcium and 800 international units of vitamin D. So really important that those folks are getting the recommended amounts of calcium and vitamin D. All right, so we made it to our last slide. These are kind of the big take-home points for our discussion. So recommended calcium, vitamin D, exercise for everyone. The evidence behind calcium and vitamin D is not super strong, but we know that calcium and vitamin D are vital for bone formation. So I'd say having a diet that is rich in calcium, getting adequate levels of vitamin D, exercising, especially when young, when you're a kid, is ideal to prevent osteoporosis. Bisphosphonates are recommended first line for most patients, both male and female. They're much cheaper and they're just more practical. IV zoledronic acid can be used if someone is not able to tolerate a bisphosphonate, but generally requires a prior authorization and very specific documentation on why they're not a candidate for an oral bisphosphonate. Denosumab, it does have some biosimilars that are approved for it. It's the first second-line agent for osteoporosis, or could even be first line if someone is very high risk for osteoporosis. This is a sub-Q injection given every 6 months at the provider's office, not at home. It has a RINS program for hypocalcemia. Then abaloparatide and teriparatide, those are once daily injectables with a max use of 2 years due to bone cancer risk. Bromosuzumab has that max of 12 months. That's due to cardiovascular risk, so stroke, heart attack. Riboside typically is just used for breast cancer prevention and just happens to have the added benefit of osteoporosis prevention. Does not have as strong data for bone mineral density. And then our typical treatment is doing a bisphosphonate for that 5 to 10 years. If someone's very high risk, maybe you would start with one of the other agents like bromosuzumab, teriparatide, more often denosumab, for however long that they are able to be used, and then followed by bisphosphonate therapy.
High risk.
Yeah, high risk, we had a slide that specifically had high risk people. So, multiple prior fractures, really high fract score, things like that. Yep. Alright. I hope you guys all have a lovely Thanksgiving, that you do some exercise, build strong bones, reduce your tolerance, and I'll see you guys next week.
Thank you, Dr.